Welcome to NUCD 2023. This is the national update on clinical diabetes, and today we are going to discuss on a very important molecule, that is semaglutide, oral semaglutide, and none other than with us is Peter Kurtzhals, the Chief Scientific Advisor at Novo Nordisk, where he has been since 1990. Dr. Kurtzhals has also previously been Scientific Coordinator for Novo Nordisk's insulin analog project, including insulin aspart and insulin detemir. Welcome to the meeting. Peter, there are so many GLP-1 receptor agonists, but why do you choose semaglutide for the oral combination?
Thank you very much for inviting me here to participate. And let me jump directly into the question here. So semaglutide holds a number of properties that makes it an ideal candidate for oral delivery. It has a relatively small molecular size, so very similar to the native GLP-1 hormone, which is useful for passage of biomembranes. It's also got a fairly good hydrophilicity, so the solubility in aqueous solution is high, also a benefit for oral delivery. And then it has a long half-life and a high potency. And the long half-life and the high potency together means that the dose that you need to give is relatively small. And that's also a benefit for oral delivery. And lastly, but not leastly, it also has a high similarity, 94% similarity to the native GLP-1 hormone, which is a benefit from an immunogenicity point of view. So many parameters contribute to making semaglutide a good candidate for oral delivery.
So while preparing the molecule, you added one SNAC, SNAC. So yes. What is that? And why did you add that?
Yeah. So if we give semaglutide alone without SNAC, the SNAC component, the bioavailability is extremely low from oral dosing. So we need to have an absorption facilitator or absorption enhancer, so to speak, and that is what SNAC is. SNAC is a small chemical molecule composed of a heterocyclic ring and a short fatty acid chain. And it interacts with biomembranes to increase permeability of biomembranes to macromolecules just temporarily, short-lived, to promote a transcellular transport of biomolecules. And it also acts indirectly and probably also directly as an enzyme inhibitor. So SNAC is a charged molecule that when it gets into the stomach and the stomach fluid, it will increase the pH locally, and due to that increase of pH, the enzymes present in the stomach, such as pepsin, will become less active because they have their optimal activity at low pH, and by increasing pH, SNAC leads to an indirect inhibition of enzymatic activity. So the combinations of an inhibition of enzyme activity in the stomach, an increase of membrane permeability, is making SNAC a useful permeation or absorption enhancer in the stomach.
In all dosings, 3, 7, and 14, why do you select such type of dosing for the oral semaglutide?
Yeah, so there are 3 doses, that's right. 3 milligrams, the 3 milligram dose is really a titration dose or initiation dose. So the recommendation is to dose with 3 milligrams to limit the gastrointestinal side effects over a period of 30 days, and then to increase to 7 milligram dose and do that for at least 30 days as well, prior to potentially going to 14 milligrams if needed to have the full benefit on glycemic control. So 3, 7, and 14 is a titration dose and 2 maintenance doses for individualized treatment.
Absolutely. So there is a problem in getting observed, semaglutide getting observed at the upper GI level and all those things, and which is taken care of by addition of snack and all those things. So can we give this molecule to people with GI disturbances, gastrointestinal problems? Can you give this molecule to them?
You actually can try. Of course, there are some particular gastrointestinal conditions where you need to take particular attention. That's with pancreatitis, for example, that will be clear from the label. But otherwise, if you are on a PPI, for example, protein pump inhibitor, it doesn't seem to affect the effect of on the uptake of oral semaglutide. So in many cases, it is still useful, but of course you have to, in some way, you can say, test that out in the individual patient, what is tolerated and what is not tolerated.
In my Indian patients or our Indian patients, we find GI tolerability is quite high. People don't react that much the way it was proposed earlier. But in my clinical practice, I don't find many people reacting to the molecule. So it is quite well accepted.
That's great.
One question comes, Peter, the snack is 300 in all the doses, 3, 7 and 14. How do you select? Because it is molecule to molecule or weight by weight.
Yeah.
Keep the snack dose 300.
Yeah, so we did experiment with that in the initiation of the clinical pharmacology program, and we concluded that 300 milligrams was the optimal amount of snack to give the best absorption in humans. And it is correct that the snack amount is the same in the 3, 7, and 14 milligram dose, and that's really because snack is affecting the membranes and the enzyme activity, as I was explaining just before, and that is needed to the same extent, no matter the dose of semaglutide. So basically, you need to have the optimal amount of snack to do what it is supposed to do to facilitate transport, and then it doesn't matter how large the dose of the active component is. You need still 300 milligrams of snack.
We know that semaglutide has a very long half-life, but why do we recommend semaglutide daily, every 24 hours?
Yeah, so the reason to go for daily administration of oral semaglutide is to limit variability from day to day. So it will take a couple of weeks to get to steady state with semaglutide due to its very long half-life. But that means that each individual dose given on a daily basis has little impact on the steady state concentration, so to speak. And that means that by giving the product daily, you will be in some way more forgiving or buffer any variability that may occur from day to day in absorption in the individual patient. So one day the absorption may be a little bit higher, another day it may be a little bit lower, but because of the very long half-life and the daily administration, it levels out to the same mean steady state concentration over time. So it's really to limit the variability from day to day administration that we give the semaglutide orally as a daily tablet rather than as a weekly tablet.
Right. When 1 year back, it was 1.5 years back, it was introduced in India, and with the hope that semaglutide is the molecule, wonder molecule, which will prevent many pathogenetic processes and give a complication-free life. But in the meantime, what we have experienced, that many people, in addition to glycemic control, are also losing weight. And that has become a real attraction for people to accept semaglutide and clinicians to prescribe semaglutide. So what our physicians or doctors, diabetologists should know about the drug interaction of semaglutide, because it will become very commonplace to prescribe it, where they should not, and all those things, drug interaction.
Yeah, and that is a good point to raise. So semaglutide may have a minor impact on gastric emptying, for example. and that could impact to a minor degree the absorption of some other medications also taken orally. So that is to be taken into account. Then there have been reported a few examples, for example, levothyroxine exposure that was increased by 33% with the concomitant dosing with oral semaglutide. But in general, the interactions that we've seen are minor. But as I said, because of the impact on gastric emptying, there may be some interactions that you need to take into account.
Some patients, due to financial effect or any other reason, want to discontinue the medicine after 2-3 months. What is your view on this?
So the view is that when you are prescribed oral semaglutide, it's because you have an important condition that needs to be taken care of. And as with any other molecule or approach to treating people with diabetes, we are talking about lifelong treatment. And that will also be the case with oral semaglutide.
So they have to take it lifelong?
Yeah, or as long as it can, remain effective in controlling blood glucose and potentially giving the weight upside as well. There may, of course, be a situation where progression is going further and insulin is needed. But until that point, semaglutide should be taken in a chronic way, so maintained as long as needed.
Many cases do require insulin along with, and that is being prescribed also. We find in India and other places, 30% of our population with type 2 diabetes are going into renal failure, kidney failure. In that case, a drug with such a long half-life, how do you recommend it?
Yeah, so we did studies with various degrees of kidney failure or of chronic kidney disease, and actually, semaglutide can be given even to people who have quite progressed kidney disease. So that has been demonstrated in clinical pharmacology trials.
So that means patients with advanced kidney problem can also safely take semaglutide.
They can, yes.
That is a clinical message that we want you to give to the audience.
Yeah.
What are the other dosage forms in which semaglutide is tried in different trials?
So semaglutide is tried in a variety of conditions, actually. In other dosage forms, that means for obesity, for example, at 25 milligrams and at 50 milligrams oral dosing. It's also being tested as an injectable. In obesity, it's approved at a 2.4 milligram weekly dose. And then there's a variety of other indications where semaglutide or the GLP-1 class of compounds appear to hold potential. And we are, of course, very excited about that. I can mention chronic kidney disease, where we have an ongoing study called the FLOW trial, in a phase 3 trial for semaglutide in chronic kidney disease. We have an ongoing trial in non-alcoholic steatohepatitis in NASH called the EVOLVE trial. We've got a trial in Alzheimer's disease where there was also indications that GLP-1 and semaglutide in particular may be beneficial. It's called the EVOKE trial. So as you can hear, there are a lot of other indications, sometimes coexisting with the diabetes diseases, or at least being diseases of the elderly, where semaglutide may hold potential, and we are looking into those opportunities for the future.
Excellent. Beyond pancreas, how do you place semaglutide, other actions of semaglutide beyond pancreas?
So the most prominent one is the effect in the central nervous system that relates to to appetite control, and potentially also to mediating effects such as those that we are exploring in Alzheimer's disease. So the GLP-1 receptors, both in the hypothalamus and in the hindbrain, and possibly also in the central part of the central nervous system that we know less about, can be quite important for some of the pharmacological actions of GLP-1.
So semaglutide is having a lot of potential benefits in the future also, and people are waiting for its weight-reducing dose of 2.4 into time to come, injectables. So it was so nice to talk to you, Peter. I would love to talk to you for hours together. It is always good to hear from the horse's mouth, but you have really thrown so much of light into the problem. I hope our clinicians and diabetologists will be very much benefited. Thank you. Thank you very much.
Thank you very much for inviting me. Thank you for having me. And I look forward to meeting in real person in India and sometime in the future. Thank you very much.
Thank you. Thank you very much. Namaste.